All right, let's just dive right in. Welcome to this explainer on multiple myeloma and related plasma cell neoplasms. If you're looking to really master this topic, you're in the right place. Today, we're building a comprehensive visual study guide together. We'll be mapping the whole journey of this disease from a single microscopic rogue clone all the way to full clinical disease and modern treatments. The goal here is to keep things highly organized and practical so you can easily lock down these concepts for your studying.
So, here's our roadmap for the explainer. We'll start with the paraprotein problem, walk through the pathogenesis, clinical features, and lab diagnosis, and then wrap the whole thing up with MGUS and modern treatment strategies. Compartmentalizing this info sequentially like this, it's honestly the absolute best way to retain it for board exams in your clinical practice. Let's get to it. Starting with Section 1, the paraprotein problem. To really get multiple myeloma, we have to look at the foundational cellular defect first. At its core, we're dealing with something called paraproteinemia. Normally, your serum immunoglobulins are beautifully diverse, right? They're polyclonal, representing the combined output of billions of normal plasma cells fighting off all kinds of antigens. But in this disease, well, imagine an antibody factory that's completely gone rogue. That diverse protective output gets replaced by a massive overproduction of identical, useless immunoglobulins. And they're all synthesized from just a single clone of plasma cells. When we detect this monoclonal band, the M protein, in the blood, that is our massive red flag. And this image brilliantly illustrates what that rogue factory actually looks like under a microscope. Look at these post-germinal center plasma cells rapidly accumulating. You can clearly see how these abnormal cells are literally crowding out the healthy, normal hemopoietic tissue in the marrow space. They're basically taking over all the real estate.
Moving on to Section 2, multiple myeloma pathogenesis. Let's look under the hood at the molecular chaos driving this unchecked growth. The pathophysiology here is basically a story of compounding errors. By the time of diagnosis, these neoplastic cells have accumulated an average of 35 somatic mutations. That is just a staggering amount of genetic chaos. An early unifying event is the dysregulation of the cyclin D family, so D1, D2, or D3. Once that instability kicks in, the cell is super vulnerable to secondary hits. Think translocations involving MYC or point mutations in RAS or TP53. But here's where it gets highly clinical. These rogue myeloma cells physically stick to the bone marrow stroma. This attachment doesn't just stop them from undergoing normal apoptosis, or programmed cell death. It actually triggers the release of high levels of a cytokine called RANKL. Why does that matter? Because RANKL directly activates osteoclasts, which are the cells that tear down bone. Lock that RANKL mechanism into your memory right now because it is the direct bridge to understanding the severe bone damage we're going to see next. Which brings us to Section 3, clinical features, specifically the CRAB criteria. How does this microscopic misbehavior turn into macroscopic symptoms for the patient sitting right in front of you? So the crucial point is right here, the CRAB mnemonic. I literally cannot emphasize this acronym enough. It is your central pillar for recognizing symptomatic tissue damage in the clinic. C is for calcium elevation, hypercalcemia, which happens because of that osteoclast-driven bone breakdown we just talked about. R is for renal impairment, because the kidneys are getting hammered by the heavy load of circulating proteins. A is for anemia, which causes lethargy and dyspnea, simply because those plasma cells are crowding out normal red blood cell production in the marrow. And finally, B is for bone lesions. We're talking severe backache, vertebral collapse, and pathological fractures. Now, what's really interesting about this slide is that we have undeniable visual proof of that B in CRAB, the bone destruction. On the left, that plain film X-ray shows severe macrodemineralization of the lumbar spine. But look at the MRI on the right. This is exactly why cross-sectional imaging is so absolutely critical. You can see the precise, catastrophic destruction at L3 and L5 actually bulging right into the spinal cord and compressing the cord. This isn't just some abstract concept, This is debilitating mechanical damage driven by that microscopic clone. This leads us perfectly into Section 4, lab diagnosis and imaging. When a patient presents with these symptoms, how do we act as detectives to confirm that clone is actually there? Let's rapid fire through these high-yield diagnostic facts. First off, we use serum or urine electrophoresis to hunt down that paraprotein spike. About 60% of the time it's IgG, and 20% of the time it's IgA. We'll also see immunoparesis. That's a drop in the normal, healthy immunoglobulins. Now, if those rogue cells are pumping out free light chains, they'll spill into the urine as Bence-Jones proteinuria, which directly contributes to that renal damage we mentioned. Check a blood film, and you'll see rouleau formation, red cells stacking up like coins, driving up the ESR. And lastly, a bone marrow biopsy will typically reveal greater than 20% abnormal plasma cells.
And speaking of that bone marrow biopsy, we definitely don't just guess at the cell count. Pathologists use flow cytometry and special stains to be super precise. Check this out. A stain using an anti-CD138 antibody reveals the plasma cells in brown. CD138 is the definitive marker used to quantify the exact burden of disease, showing us exactly how extensively the marrow has been infiltrated.
All right, Section 5, MGUS and related neoplasms. Multiple myeloma doesn't just pop up overnight. It exists on a spectrum. Let's talk about the progression from benign precursor states to full-blown malignancy. Walking through this comparative table is incredibly important. We're looking at MGUS, that's monoclonal gammopathy of undetermined significance, compared with smoldering myeloma, and finally, symptomatic myeloma. This shows you exactly where the benign MGUS smolders. You've got less than 10% marrow plasma cells, a very low paraprotein level, 0 PLAB features, and only a 1% yearly risk of progression. But look at the thresholds where it escalates. In smoldering myeloma, plasma cells hit 10% or more, and that progression risk jumps to 10% per year, though still no clinical symptoms. It finally ignites into symptomatic myeloma the moment those CRAB clinical features, the actual tissue damage, show up. Finally, Section 6, modern treatment strategies. We know the enemy, we see the damage, we know how to track it. So, how do we use modern pharmacology to launch targeted strikes against this rogue clone? Let's see how this builds into an intense, multi-step standard of care, especially for fit patients, usually younger than 70. The main goal here? Massively reduce the tumor burden. The journey kicks off with induction therapy, typically a pretty rigorous 3 or 4 drug combination. Once the tumor cells are knocked back, we move to Step 2, mobilizing and collecting the patient's own healthy stem cells. Step 3 is the conditioning phase, using high-dose chemo like melphalan to basically wipe the slate clean in the marrow. Step 4 rescues the patient by infusing their collected stem cells back in, an autologous stem cell transplant. And finally, Step 5 is maintenance therapy, often relying on a drug like lenalidomide to keep the disease suppressed for as long as humanly possible. But what exactly is in those drug combinations? Honestly, we have an incredible targeted arsenal today. It is truly amazing to see the massive shift in myeloma care. We've moved from broad, generalized chemotherapy to highly specific, smart therapies. We use proteasome inhibitors like bortezomib and immunomodulators like lenalidomide. But the real game changers? The immunotherapies. We've got monoclonal antibodies like daratumumab that specifically hunt down and destroy cells expressing the CD38 antigen. We also utilize bispecific antibodies and even advanced cell therapies like CAR T cells, completely engineered to seek out the BCMA antigen on the surface of these rogue plasma cells. And that really brings us to the absolute frontier of hematology. For decades, the entire goal of treating multiple myeloma was just to control symptoms and prolong a good quality of life. It was considered fundamentally incurable. But now, with the advent of these incredibly precise cellular weapons, like anti-BCMA CAR T cells and bispecific antibodies, the whole paradigm is shifting. It leaves us with a really provocative question. Are we standing on the brink of finally turning this complex, devastating condition into a curable disease? It's an absolutely fascinating space to watch. Thank you so much for joining me on this explainer. Keep studying smart, and I'll catch you next time.